All right, we're going to go through all the hip muscles, and I'm going to do the order a little bit differently from how it is in the book. In the book, they talk about the different hip muscles and the functional aspects of those muscles. I'm going to split that up. We're going to talk about the muscles specifically in this section. In the next section, we'll talk about the functional considerations. Also in the book, they have some pretty detailed origin and insertion descriptions. You don't necessarily need to know that level of detail, and they're in the PowerPoint too, because this PowerPoint is from the book. In the module and in the lab manual, I have the list of hip muscles, and that's pretty much the level of detail that I want you to know on the origins and insertions. So I'll talk about them here, and then we'll review them. So first we'll talk about the hip flexors, and our biggest, most powerful hip flexor is the iliopsoas, which is really a combination of two muscles, the psoas major and the iliacus. So the psoas major has the most superior attachment, and then they join together and they share a common insertion. So the psoas major, its origin or proximal attachment is the transverse processes and lateral bodies of T1 through L5, lumbar, thoracic and lumbar vertebrae, including the discs. And its distal attachment is, along with the iliacus, the lesser trochanter of the femur. The iliacus is seated in the iliac fossa, the anterior part of the ilium, and its distal attachment, it shares with the psoas major, it's the lesser trochanter of the femur, and they do hip flexion. They are major hip flexors and anterior hip rotators, and we will talk about anterior and posterior pelvic tilt in the next section. But really, tightness or weakness of the iliopsoas can really cause a lot of back, trunk, pelvis, and hip problems, and so it's something that we address frequently in physical therapy. Because they're hip flexors, they get the femoral nerve. Okay, the next hip flexor that gets the femoral nerve is the rectus femoris. It is actually one of the quadriceps group, the only one that crosses the hip. So we'll be talking about the other three in the next chapter when we talk about the knee. And the rectus femoris attaches, its origin is at the anterior inferior iliac spine. Its distal attachment is the tibial tuberosity via the patellar tendon, which it shares with the three other quadriceps. So its primary actions are hip flexion and knee extension. And it's a multi-articular muscle. It crosses two joints. So because the rectus femoris crosses both joints, the position of the knee really influences the function of the rectus femoris at the hip, and vice versa. So if the knee is in a certain position, you're more likely to reach active or passive insufficiency with the rectus femoris. And a lot of our functional positions, like sit to stand, the knee will be opposite. So the knee will be flexed and the hip will be flexed, and it keeps the rectus femoris from getting into that position of active or passive insufficiency. And of course, it's a hip flexor, so it gets the femoral nerve. Our other hip flexor, which isn't a major hip flexor, is the sartorius. It's the longest muscle in the body. It goes diagonally across the anterior thigh, and it's the most superficial muscle in the anterior thigh. It originates at the anterior superior iliac spine, and its distal attachment is the anterior medial aspect of the proximal tibia. It shares a common tendon with the gracilis and the semitendinosus, which is called the pes anserine. So its actions, it has a variety of actions. When you see its line of pull, that makes sense. Hip flexion, sure, because it's an anterior muscle. Abduction, because it has a little bit of that medial-lateral line of pull. Since it crosses across, so since it goes from anterior to posterior, it can do that rotation. And because of the way it crosses the knee, it can assist with knee flexion and knee internal rotation. So if you can't remember what the Sartorius does, all you have to do is cross one foot over the other knee or sit cross-legged, and your Sartorius will be in its shortened position. Its primary action is hip flexion, and so it gets the femoral nerve. The tensor fasciae latae, it's grouped with the hip flexors, and it does have a line of pull for hip flexion. It's not a major hip flexor, though. I mean, we have big other muscles that can do it much better, and it's not innervated like the hip flexors. It also has a slight line of pull for hip abduction and hip internal rotation, very slight. It's a tiny little fusiform muscle with a really long tendon. And so it basically functions as a stabilizer. It can do those other motions, but its main function is to tighten the IT band, providing increased stability across the lateral aspect of the hip and the knee. So it's more of a stabilizer than being a prime mover for any of those actions. And it originates on the outer surface of the iliac crest, just posterior to the ASIS, so it's like the next door neighbor of the gluteus medius. And the distal attachment is on the iliotibial band, because it tenses that band. So it gets the superior gluteal nerve, just like the gluteus medius, and I think of it as like neighbors who share a Wi-Fi connection. So it's the neighbor of the gluteus medius, and they share innervation with the superior gluteal nerve. The gluteus maximus, going into the hip extensors, it's a big, broad muscle. It has a really broad proximal attachment and a really broad distal attachment. It's a rhomboid muscle. So it's a strong hip extensor that's often involved in power moves, anti-gravity activities such as going uphill or going up steep stairs. So the proximal attachment is all across the posterior ilium sacrum and coccyx, and the sacrotuberous and sacroiliac ligaments. The distal attachment is the gluteal tuberosity of the femur and the iliotibial band. So because it's posterior to the medial lateral axis, it does hip extension. It has those oblique fibers, so it can do hip external rotation, and it's one of the players in the posterior pelvic tilt, which we will talk about in the next section. It gets its own nerve, the inferior gluteal nerve. You can think the gluteus medius origin is superior, it gets the superior gluteal nerve. The gluteus maximus origin is inferior, it gets the inferior gluteal nerve. That's how I remember it. So the next group of hip extensors is the hamstrings, and they're also knee flexors. So because they're two joint muscles, they could potentially have a active and passive insufficiency. The gluteus maximus is a one joint hip extensor. So for all of the hamstrings, the proximal attachment is the ischial tuberosity. We have two that are medial and two that are lateral. The medial superficial hamstring is the semitendinosus. So it goes from the ischial tuberosity to the distal attachment at the pes anthrinus, which is the anterior medial aspect of the proximal tibia, shared with the sartorius and the gracilis. It does hip extension. It's one of the major hip extensors. It's a player in posterior pelvic tilt. It's a big player in knee flexion. And because of its line of pull, it can play into knee internal rotation. And we will talk about that more specifically in the knee chapter. Because it's a hip extensor, it gets the sciatic nerve, it gets the tibial portion of the sciatic nerve. So, the long head of the biceps femoris is the other superficial hamstring. It's the lateral superficial hamstring. Again, it originates at the ischial tuberosity, and its distal attachment is the head of the fibula. The short head of the biceps tendon is the only one of the hamstrings that is not a two-joint muscle. It originates on the femur, but the long head of the biceps femoris crosses the hip and the knee, It does hip extension, posterior pelvic tilt, knee flexion, and knee external rotation. So it's sort of the opposite rotation from the semitendinosus. And it gets the tibial portion of the sciatic nerve. The semimembranosus is the medial, deeper hamstring. Again, it originates on the ischial tuberosity. The distal attachment is the medial condyle of the tibia, the posterior aspect. It does hip extension, posterior pelvic tilt, knee flexion, and knee internal rotation, just like the semitendinosus. So the hamstrings, you can think they have common actions. Whether they do internal or external rotation at the knee depends on whether they're medial or lateral. And but they all do hip extension, posterior pelvic tilt, and knee flexion. And they all get the tibial portion of the sciatic nerve. So on to the hip abductors. The gluteus medius is kind of our major hip abductor, and its little buddy, its little helper, the gluteus minimus. So the gluteus medius attaches on the outer surface of the ilium. It's a triangular muscle, so it has a broad proximal attachment and a small distal attachment. Its distal attachment is the greater trochanter of the femur, and it does hip abduction. It's the largest of the hip abductor muscles, and it has, in the book it says it occupies about 60% of the total abductor muscle cross-sectional area. Very interesting. It's also a muscle that we're very concerned about in physical therapy. We work on the gluteus medius a lot, and part of it has to do with the weakness of the gluteus medius and how it affects your stability in walking. And we will talk about that in the next section. So its primary action is hip abduction, but because of the fan shape of its fibers, the anterior fibers can assist with hip flexion, internal rotation, and the posterior fibers can assist with extension and external rotation. So because of its shape, it has fibers that can assist with some of those other motions, and it gets the superior gluteal nerve, which it shares with the tensor fasciae latae and the gluteus minimus. So the gluteus minimus, it's deep to the gluteus medius. It has a similar shape, it's just slightly smaller. It's slightly anterior and deep to the gluteus medius. So it does have a line of pull for internal rotation. Its anterior fibers do, and it can do a little bit of assist with flexion. But its main action is hip abduction, and it shares that superior gluteal nerve with the gluteus medius. So it's the outer surface of the ilium, just inferior to the gluteus medius and slightly anterior, and the distal attachment is the greater trochanter. So on the other side of the coin, the hip adductors, the pectineus, there's always got to be an oddball, and the pectineus is a little bit of an oddball. Its proximal attachment is the pectineal line on the superior pubic ramus. It is the most proximal attachment of any of the hip adductor muscles. The distal attachment is the pectineal line on the posterior surface of the femur. So it has that medial lateral pull for hip adduction, but because it goes from anterior to posterior, anterior on the pelvis to posterior on the femur, it can also do hip flexion. It's innervated by the obturator nerve, but it also has some innervation from the femoral nerve. So it has that line of pull for hip flexion. Kind of an interesting little muscle. You always have to have a weird one. But it is the one that has the most proximal attachment of any of the hip adductors. The three other hip adductors, adductors, are the adductor longus, brevis, and magnus, and the gracilis. So the longus, brevis, and magnus all sort of stack right up, and the gracilis is like the inside seam of your pants, if you want to think of it that way. So the proximal attachment of the adductor longus is the anterior surface of the body of the pubis. and the distal attachment is the middle third of the linea aspera. So it also goes to the from the anterior pelvis to the posterior femur. So it has the medial lateral line of pull for adduction and that anterior posterior line of pull for hip flexion. And it gets the obturator nerve. If you look, these guys attach so close to the obturator foramen, that's a really good way to remember that they get the obturator nerve. So the adductor brevis, its proximal attachment is the anterior surface of the inferior pubic ramus, so it's a little bit inferior to the adductor longus. And its distal attachment is the proximal 1/3 of the linea aspera. So again, it has that line of pull for hip flexion and the medial lateral line of pull for hip adduction. And it gets the obturator nerve. It's right there next to the obturator foramen. The adductor magnus is huge. It is the largest, most massive, and deepest of the adductors. It has a little opening in it. It's called the adductor hiatus in the distal attachment between the linea aspera and the adductor tubercle. That opening or hiatus is a passage for the femoral artery and vein. After the femoral artery and vein pass through that hiatus, their names change to the popliteal artery and vein. Sort of like the sciatic nerve, when it splits into the tibial and the common peroneal. The femoral artery and vein pass through that opening and change their name. It's kind of like the streets in Bellingham. You cross a certain street and suddenly you're on a different street, but I never thought of it that way. Back to the muscles, the adductor magnus has an extensor head and an adductor head. So we'll talk about each one of those separately in terms of their insertion and origin, insertion, and their action. Same innervation though, obturator nerve. Anything with the name adductor in it has an obturator nerve. It does get a little bit of innervation on the extensor head from the sciatic nerve though. So the adductor head is the anterior head, and the extensor head is the posterior head. So if you think about the extensors being posterior, that kind of makes sense. So both the extensor head and the adductor head are primary adductors, but the extensor head also helps the hamstrings, and it's similar in its innervation. It's innervated by the sciatic nerve. So it does hip extension, and the attachments are similar. So it's just like the hamstrings, it attaches on the ischial tuberosity, the extensor head, and its distal attachment is the adductor tubercle of the distal femur. So it does hip extension and adduction, and it gets the sciatic nerve, that extensor head. So you can think of it as it's like the neighbor to the hamstrings, and it's sharing their Wi-Fi. I never thought of it that way before, but from now on I'm going to think of it that way. So the adductor head is the anterior head. Its proximal attachment is the ischial ramus, and the distal attachment is the entire linea aspera of the femur. So it has a very broad distal attachment. It's like the upside down triangle, if you want to think of it that way. It is similar to the adductor brevis in its innervation. It's got the obturator nerve, and it does a little bit of hip flexion, similar to the other adductors, and it's a major hip adductor. So a lot of times you can, in the book they show a lot of the muscles in isolation, but they don't function in isolation. Sometimes you have to see what their neighbors do. What innervation do the neighbors get? What action do the neighbors do? How does their line of pull influence their action? So these are the questions we need to ask ourselves. The gracilis is the last of the hip adductors, and it is a two-joint muscle, so it crosses the hip and the knee. The tendinous insertion is part of the pes anserine, and it provides some medial support to the knee. Its proximal attachment is the body and inferior ramus of the pubis. So I think of it as being like that inside seam of your pants. It does hip adduction. It has the tiniest little line of pull for hip flexion. Obviously, we have other hip flexors that are doing the job. It has the tiniest little line of pull for knee flexion, but we have other knee flexors that are doing the job. And it also has a little teeny stake in knee internal rotation. And it is innervated by the obturator nerve. So as far as external rotators go, we have these 6 short external rotator muscles that are deep, mostly posterior muscles. They're deep to the gluteus maximus. And they span the hip joint horizontally, performing hip external rotation. I do not necessarily want you to memorize all of the different origins and insertions. Just know that all of the 6 deep hip rotators originate on the posterior sacrum, ischium, and pubis and insert on the greater trochanter area. So they have that line of pull for external rotation. The main one that we deal with in the clinic is the piriformis, and the reason that one rears its ugly head pretty frequently is because it's the only one of the deep hip rotators that passes over the sciatic nerve. So if you have a tight piriformis, it can cause pain radiating down the back of your leg. It can cause sciatica. So there's actually a name for it. It's called piriformis syndrome, and for that reason, we will engage with it more than we do the other deep hip rotators. And the deep hip rotators, they all have their own little nerves. So they have, the piriformis has its own nerve, and the obturator internus has its own nerve. So it's not any of the major peripheral nerves. You just have to think of them each having their own nerve. I guess that's all I want you to know about those guys. So the hip really has no primary internal rotators, even though it has several secondary internal rotators. What the internal rotators do is they kind of help change the direction of the advancing limb and balance force of the other flexor muscles. So the anterior fibers of the gluteus medius can do a little bit of internal rotation, and the gluteus minimus. The tensor fasciae latae can do a little bit of internal rotation, the adductor longus and the adductor brevis. Even though none of them, it's their part-time job. None of them are fully employed doing hip internal rotation, but they all moonlight a little bit in the hip internal rotation just to help stabilize the pelvis.